And good morning, everyone. I'm Dr. Ken Williams, Chair of Medicine here at University of Louisville, and it is my pleasure to introduce the introducer of our 2026 Beverly Todd Towery Lecture. The lecture will be given by Dr. Yogish Kudva, who is with us from Mayo Clinic. He'll be talking about AIDE, that's automated insulin delivery and type 2 diabetes mellitus in the elderly. But to give him a proper introduction, I'm going to turn it over to our division chief, Dr. Sri Mokshagundan, who will give us the introduction to both Dr. Kudva and tell you more about Beverly Todd Towery, the 15th chair of medicine here at University of Louisville. Dr. Mokshagundan, thank you.
Good morning, everyone. Thank you for attending this lecture today. Today we honor Dr. Beverly Todd Towery, who was from Kentucky, born here in Kentucky in 1915. He grew up in Southern Kentucky and went to Western Kentucky University, State College at that time, and then went to medical school at Vanderbilt, and had his training in endocrinology at the Thorndike Memorial Laboratories in Boston. He had also did his internal medicine residency at the Mass General Hospital. He served in the United States military during World War II, and subsequently came back and set up the Division of Endocrinology at Vanderbilt University. In 1956 was when he started that, and then he moved to Louisville as chair of internal medicine. He was chair of internal medicine until 1970, when he stepped down as chair of internal medicine and continued to be the chief of the Division of Endocrinology. Unfortunately, in 1974, he was struck by viral encephalitis, and he passed away eventually in 1981. He was well known for his scientific rigor and teaching, and so his students and his colleagues set up this lecture, and over the last 40 years, we've had very distinguished speakers come here to deliver this lecture in his honor. And today we have equally eminent scholar come here to talk to us about automated insulin delivery in type 2 diabetes mellitus in the elderly. Dr. Kudva is a professor of medicine at the Mayo Clinic and the Division of Endocrinology, Metabolism and Nutrition. He's graduated from medical school at St. John's Medical College at the top of his class, did his postgraduate training at the Postgraduate Institute in Chandigarh in India. And then he came to the Mayo Clinic as an internal medicine resident in 1994 and has been there since then, finishing his endocrinology fellowship and joining the faculty and moving up the ranks to be a professor of endocrinology. He has been outstanding clinician, has been a great clinician investigator, and has been a pioneer in the field of diabetes technology, artificial pancreas systems, and cell-based therapies for type 1 diabetes. He set up the diabetes technology program clinic way back when very few people knew anything about it. So the infrastructure that he set up with the Diabetes Technology Clinic in 2003 has served very well to be kind of the focus for conducting a number of trials that have now been well validated and have become a standard of care. So he's also worked in the field of cell-based therapies and gene therapy and regenerative medicine teams. He is widely published, over 240 peer-reviewed articles. His research has been funded by the NIH, Helmsley Foundation, and other agencies. So we are very pleased to have him come to Louisville and talk to us today at the Beverly Todd Lecture. Dr. Kudva.
So that was a very kind introduction, Dr. Mokshagundam. Thank you. And also thank you to Dr. Williams and all of my hosts here. It's been a great pleasure being here for the last day and today. So yesterday and today. So Dr. Mokshagundam was one of our faculty when I was in medical school in St. John's in Bangalore. And he was one of a group of role models that we were very, very fortunate to have, inspiring us with their commitment to lifelong learning and also a great deal of humility. So I have endeavored to follow that in the course of my career, and I've been fortunate to be on faculty at Mayo Clinic now. This is my 28th year there on faculty. So I have consulted for Tandem Diabetes, Vertex Pharmaceuticals, and Novo Nordisk, and all of the funding is paid to a Mayo Research Fund that covers the time that I spend away from patient care, providing expertise to these organizations. And some of the technology organizations such as Dexcom and Abbott and Insulet have provided product support. And there may be more in this list as the year progresses. I will, when there is any kind of current or immediate future, conflict, point that out. But I have no stock in any of these organizations. So we have two broad objectives today: to look at clinical trial evidence for automated insulin delivery in type 2 diabetes, and then to look at clinical trial evidence for automated insulin delivery in elderly in type 1. And also I'll comment a bit about the same for type 2. So the Control-IQ system that Tandem has is now a commercial platform and has been so for several years. So Tandem, the insulin pumps made by Tandem, initially called TAP and later called T-Slim X2, were being used as open loop platforms, open loop systems prior to 2020. So at the University of Virginia, Boris Kovachev, who is a mathematician, came up with their Center for Diabetes Technology and the algorithm that would control insulin delivery in response to continuous glucose monitoring signals in about the second decade of this century, so 2010 onwards. So the NIH, Helmsley Trust, and JDRF, funded further development of these studies. And the NIH put forward a unique real-world study grant called the UC4. And we were fortunate, since we had done work with Dr. Kovachev prior to the grant, to be an active part of that grant. So that resulted in an upscaling of the Control-IQ system into a pivotal study in 2018, and ultimately approval of the system by the FDA in 2019 December. So subsequently, as the system got rolled out and endorsed by people with type 1 diabetes, the immediate next step, therefore, one of the immediate next steps would have been to test this in type 2 diabetes. So this was an initial feasibility study that was done, and Carol Levy at Mount Sinai was the protocol chair for this, and we at Mayo Clinic, and then Tom Levins at a CRO in Texas, where the three sites that did this initial feasibility study in 30 people with type 2 diabetes who used Control-IQ for 6 weeks. And we showed an increase in time in range in 70 to 180 range by about 15%, with no increase in hypoglycemia. So endocrinologists would remember that with the ACCORD studies in the first decade of the century, there was significant concern that as we try to intensify glucose control in type 2 diabetes, there would be, that as we attempted to do that, we didn't expect so much adverse events as happened. And the thought was this was maybe hypoglycemia related. This was not an era in which real-time CGMs were available. And so therefore, subsequent studies have been approached with a lot more change in tactics. So the ability to show no increase in hypoglycemia was important prior to moving into a pivotal study. So the pivotal study was then conducted in 2023. And this is the design. So it was a 13-week randomized controlled trial, 21 centers in North America, and one VA hospital as well. Those subjects who entered had to be on either multiple daily insulin injections or an insulin pump. And they were all adults with type 2 diabetes. They were randomized 2:1 to either the AID use or to use continuous glucose monitoring. And the primary outcome was hemoglobin A1C at 13 weeks. So these are the sites, and we at Mayo Clinic were pleased to contribute about 8% of the patients. So 21 centers, each one would have about 5%, but some of us exceeded that expectation. So these were the eligibility criteria. Individuals had to be greater than 18 years of age with established type 2 diabetes and A1C below 11%. And they had to be using basal bolus insulin therapy for 3 months. And they could not change non-insulin glucose-lowering medications during the study. And also their dose had to be stable for at least the last month prior to the study. There were no A1C limitations apart from the 11%. So because of this being a population with type 2 diabetes and with heterogeneity as part of the baseline characteristics of patients coming in, a priori we had set down eligibility buckets. So 30% had to be minority, 10% had to be greater than 50 years. We exceeded this widely, and then there were so many other criteria here, and we will look at that as the study results come up. So the AID group training was kept as close to real world as possible. There was only one type of insulin used in the pump, and this was Novolog. And the continuous glucose monitoring group continued to use their pre-study program, insulin delivery program, and their medications. And A1C, lipids, and creatinine were measured at a central lab at randomization and at 13 weeks. Because of the concern that perhaps there could be some people with type 1 diabetes who had been undiagnosed, there was a central lab C-peptide and glutamic acid decarboxylate antibody measurement that was done to be used as post-hoc analysis. And then we had patient-reported outcome surveys at baseline and 13 weeks. So these are the baseline characteristics here. 58 years of age with 48% female, 18 years of diabetes with about 57% that had education below a bachelor's degree level. And as we can see, income, insurance, etc., mirror our general practice. And we fulfilled the race eligibility with 30% non-white people. I apologize for the error here. This is 8 to 8.9%, being 28%. This is A1C. And then the others were all in various appropriate buckets. And I'll talk about this as we go further. So our minimum recruitment goals were exceeded here, for example, the minority race, we actually enrolled 39% minorities. And greater than 50 years being 10%, we had at 74%. And then MDI users were at 96%. And only 4% were insulin pump users going into the study. This is important because as patients with type 2 diabetes require complex insulin therapy, one of the questions is, should they get multiple daily insulin injections and fail them before they go on to AID system, or can they go on to an AID system if there is sufficient interest from the patient's side? And then the tandem insulin pump is set up with an algorithm which does 100 units of insulin per day. Now, exceeding that, how good would the algorithm be? We wanted at least 15% in there like this, and we were at 40%. Considering that people with type 2 diabetes, a vast majority of them just do fixed dosing at meal times, we try to keep it simple for patients, So if they wanted to do fixed dosing, we just gave them a fixed dosing program, and that was 75% of the population. So carb counting and an alternate way of looking at meals such as small, medium, and large, as also not announcing meals, was 25% of the population. And then GLP-1 users, SGLT2 users, we far exceeded our enrollment projections. And a combination of both, again, we exceeded that. And A1C greater than 8% was 61%. We wanted it to be 40% at the start. So we had 319 subjects that were enrolled, and 2:1, so 215 with automated insulin delivery, and 104 in the standard group. And as we can see, both groups had about an equal percentage that dropped out. And the AID individuals, some may have stopped using the AID, but we still had CGM data and we analyzed them in the same cohort. So all the analysis was done by the Dept Center, which has really got the deepest, statistical expertise in this space. So our primary endpoint here was A1C, and as you can see, the A1C was reduced by 0.9%. And it is very important to look at how much does continuous glucose monitoring itself impact glucose change. And we saw 0.4% change there. So therefore, between groups, the difference was 0.6%. So this is the first study that really showed us in a pivotal manner what the impact of using a CGM versus the impact of using an AID system would be. So we had many more secondary endpoints. So A1C less than 7% was achieved by a statistically higher group in the in the AID group, 37%. And A1C improvement of greater than 0.5% was 59%. The improvement by greater than, you can see, was 3 times as high as in the CGM. The time in range improvement was about 16%. So the control IQ system in people with type 1 diabetes got a mean time in range of 71%. So that was in the New England Journal in 2019. And so in type 2 diabetes, the efficacy was a bit less, but the A1C improvement was quite a bit more. And you can see that the CGM group, there was not a difference there. But when we looked at various other CGM metrics, in every one of these, the AID system was superior. So the improvement here happens immediately. As you can see, this is the weeks, and inset here are the days. So you can see that red is the CGM and blue is the AID. And the mean percentage in range 70 to 180 exceeded 70%. This improvement happened in the first week and in fact in the first day. And then that is sustained throughout the 13 weeks. And then the time in range you can see that the improvement is present throughout the 24 hours. So in people with type 1 diabetes, the difference in time in range is most profound overnight. And in the day, that effect size is smaller. But in type 2 diabetes, that effect size overnight is larger, but is larger than in type 1 during the day as well. So the 16% change reflects this in 24-hour based improvement. So the A1C change from baseline that we saw here, we looked at various other determinants of this. Obviously, one of the questions is GLP-1 receptor agonist use. How much of a difference would there be? And there wasn't really a difference. AID group in GLP-1 users versus non-users was not significantly different. What about weight? What about body weight outcomes? So in the GLP-1 users versus the non-GLP-1 users, you can see that the AID weight change was maybe a bit different. So there was a 1.7 kg change here in increase in the GLP-1 users, and in the non-GLP-1 users, it was a 2.9 kg change. So with that translates into about 1.5, 1.3 pound change per month in the GLP-1 users, and about a 1.8 pound change in the non-GLP-1 users. So yes, it does increase body weight, and that is something we have to be vigilant about in clinical practice. And most of the patient-reported outcomes did not show a meaningful difference. There were some positive responses in the AID group in terms of satisfaction of the patients with the treatment, and also sleep quality was better in the AID group, which obviously is an important issue because it could have other impact, including daytime blood pressure in these patients. So safety is an obvious concern here. There was one severe hypoglycemic event in the AID group. And so this was exploratory and of some concern, but not statistically significant. And overall, other serious adverse events were no different. It was 7% in both groups. So to summarize, this was a pivotal randomized trial because it was the first pivotal randomized trial for type 2 diabetes of AID. It is considered a significantly high impact, and the FDA approved this almost simultaneous with the NEJM publication. And then the A1C improvement here is 0.9%, and the mean difference between that and using CGM is 0.6%. And the time in range is substantively improved. And there are similar improvements in all other CGM metrics and no safety concerns. So additional conclusions here are that it is beneficial for people with type 2 diabetes who have been using predominantly MDI, and that the strict restrictions on co-interventions having a control group made this a unique study and clearly differentiate the impact of each type of technology use. So just to illustrate here, there are many success stories. We had this lady who had been struggling with type 2 diabetes with an A1C greater than 9%. She did need some oversight, particularly with regard to device support using the device, but improved her A1C by 1.7%. So almost simultaneous with this, the Insulet Corporation, using their Omnipod 5, did a non-randomized clinical trial, and you see the flow of patients here. So this was also analyzed by the Jaeb Center, and Dr. Roy Beck was the medical monitor for this study as well. So you can see that there were about 296 patients with Omnipod 5 use that were analyzed here, enrolled and analyzed. And a similar population, so average age close to 60, like in our population. And almost all of the rest of the categories were very similar. So this was an FDA oversight study with the data to be submitted to the FDA. And our enrollment characteristics versus theirs were also somewhat similar. So I made a an error in one of the slides for the control IQ study, but our buckets for both are similar here. So therefore, greater than 8% was about 50% here into 61% in our cohort. Other baseline characteristics also are very similar to what we wanted to capture and reflect the population in general. So greater than 100,000 income was only 22% of the population. So much more reflective of our usual population. And MDI users in the study were 73%. In addition to MDI users, those who used basal insulin only could be eligible for the study, and that was 21%. So that's the additional issue here, addressing the issue of when people need multiple injections, should they do multiple injections or should they be given the option of doing an automated insulin delivery system? So similarly, GLP-1, SGLT2, and the combination was captured here, and substantive proportions were on one or the other or both. And those on neither, likely because they couldn't tolerate it, but we don't know the answers to this because we didn't capture those data, or the study investigators here, we were not part of this study, did not capture the data. So about 28%, so a quarter to a third generally cannot tolerate either medication or it's not used. Obviously, they have other comorbidities, and that's illustrated on this slide. And then the measurement of GAD antibodies, we did and they did, and it's very similar. I think the numbers with high titers, about 4% or so, and the numbers that are positive in general is about 7%. And we don't have time to go over these data, but neither GAD antibodies nor C-peptide makes a difference to the outcomes. The time in range is improved. Similarly, in both the groups that have GAD antibodies and those with a lower C-peptide. So you can see the impact of the closed loop system here was 0.8%. There is no comparator group. And the impact in terms of the time in range is about 20%. So higher than in the 2IQ study. But again, there may be some difference in characteristics between patients in the two studies, so you cannot really compare the two studies. Suffice to say, they are both significant number of patients, so therefore we should have confidence in these data. So when multiple factors were looked at in terms of the improvement in A1C, we can see here that the higher the A1C, more the impact. And in terms of ethnicity, some ethnicities may have a higher impact compared to others. And interestingly, Hispanic or Latino and other ethnicities, the impact was higher. GLP-1 receptor use or not, there was not a difference. So these were the only two factors which stood out. There were many other factors here which were analyzed, baseline factors, as part of the primary statistical analysis plan. They were not significant. So I'm just showing you a few key ones here. So the Omnipod 5 system as an AIDE is safe and beneficial in a diverse population of type 2 diabetes. So that's the additional take-home message here. Apart from all the other points made with the control IQ, which are true, except for in the control IQ, there was a CGM intervention where there wasn't. So where do we go next in this field? So the Insulet is going to have another version of the Omnipod, and they tested it initially with the evolution study. And this was done in New Zealand. And the idea here is to do a more full closed loop. That would mean avoid meal announcement and maybe even limit exercise announcement. So to do this, they had an initial feasibility study N of 12, type 1 diabetes, N of 8, type 2 diabetes, and had this in like a 48-hour hotel phase. And this we've done in type 1 and in type 1 pregnancy. So this is just sort of recreating the same pathway to approval, making sure there is adequate safety. And once that is achieved, then moving on to at-home 6 weeks. And they have an Evolution 2 study, and then the fully automated insulin delivery system for Omnipod will be tested in type 2 diabetes starting later this year. So there is the twist pump that we looked at yesterday in endocrine grand rounds. So the twist pump has interesting differences, including the ability to control glucose to a lower target range. So the pivotal study for that has been completed. We were part of that study. Data are being analyzed, and AIDE this year will have a presentation of the results. And Medtronic has their M351 study, the Gateway trial, which is going to start this year. So I think the next 1 to 2 years, we will have a lot more options for people with type 2 diabetes. So what about elderly people? And that population is growing. So older adults with type 1 have long-standing diabetes and may have hypoglycemia unawareness, and they represent a growing population. And hypoglycemia in these individuals is not trivial and may result in falls, fractures, cardiac arrhythmias, and may go on to severe hypoglycemia. So among Medicare beneficiaries, it has been increasingly apparent from about 2005 to 2015 that hypoglycemia is more of an issue than hyperglycemia, and a proportion of them are type 1. And then the AID systems obviously need to be tested in this cohort as well. So there have been studies reflecting this that have been done around the world. This is the UK study, and the UK study was also done at one center in Austria and used the Dexcom CGM and the Dana insulin pump. So this is Roman Hovorka and his group, and they have their own model predictive control algorithm, which the ecosystem involves a Samsung phone. So individuals here were greater than 60 years of age. And as you can see, this was a smaller scale trial. So there was some imbalance in terms of sex inclusion. And this population continues to be predominantly white. And though there is an occurrence of this in non-white populations, we need to do better in terms of enrollment. And as you can see, a proportion of this population does have diabetes-related complications. So this was a crossover study. So either patients were randomized to AID or to sensor-augmented pump. And the A1C criteria are shown here, and they're really no different from the other older adult studies, and we'll go over those in. We'll compare this to those studies in the subsequent slides. So time in range, at baseline is about 70% in this population here. And older adults have a better time in range at baseline. So you can see the usual other characteristics captured, particularly the fact that their insulin use is about 0.5 unit per kg per day. So the results here show an impact of close to 9% improvement. So in adult population, that improvement is probably closer to 14%, but in the senior citizens is about 9% in this cohort. Other endpoints were all significant except for time below 70. So time in hypoglycemic range was not different between the two groups. So the overnight improvement, as you can see, is much higher than the daytime improvement with closed loop. And this is a theme that runs through the type 1 trial space. The overnight impact is bigger. Hypoglycemic range was not different. There were some differences in terms of total daily basal insulin use in one group versus the other. And it's interesting with AID, the insulin use is a bit less, but most importantly is the insulin is provided at the right time based on the CGM signal. Closed loop use and CGM use are really enriched greater than 95%. And that is what we should endeavor to do in our clinical practice in these patients. And severe hypoglycemic events and severe adverse events were not different. Of course, the study with this sample size was not powered to find any dramatic differences, but this is reassuring. So HCl or AID is effective and safe in older adults. AID is the more accepted terminology now, but you see HCl constantly being used in publications prior to the last couple of years. So this is an Australian study entitled as the Oracle. And again, this was a crossover study and had 2 4-month periods and was conducted at 2 Australian centers and closed in the early months of the pandemic. So again, 30 subjects, a priori sample size was intended like that. And the age at enrollment was greater than 60 years, and the range was 75 years. So, meaning the upper limit of the range was 75 years. And again, there is some imbalance here in terms of sex enrollment. For the rest, you can see the characteristics here, and the CGM use at study entry was only 40%. So that is changing with every passing year. So additional characteristics here, the A1C at baseline was 7.6%, and you can see the C-peptide measurements were quite low. About a third of people here had impaired awareness of hypoglycemia. So these authors have to be congratulated on also doing a detailed neuropsychiatric evaluation, and they enrolled 20% of people with mild cognitive impairment. They also looked at frailty, and here at least they had a 20% pre-frail population. They did additional assessments beyond the frailty of physical status, including sarcopenia, walking speed, grip strength, and activities of daily living, and physical activity assessment. And more importantly, caregiver assistance for diabetes management. And we'll return to that in a couple of minutes. So they measured other patient reported outcomes, including the hypoglycemia fear survey developed at the University of Virginia. So the results as shown here show an impact of about 6% difference in time in range. And that was statistically significant. So there were some differences in many differences in CGM that were statistically significant, and some other assessments of glucose control, such as an A1C change, for example, that were not statistically significant. You can see the bigger impact here overnight and the lesser impact during the day. And then, the percentage of time in range, you can see much higher overnight, much less during the day. And looking at other CGM metrics, we can see percentage of time above range, also much more improvement overnight compared to during the day. And time in hypoglycemic range, you can see that the closed loop impacts much more than SAP. So the overnight change of 10% really stands out here. The daytime changes 4.9%. So, but overall, the difference here was about 6%. So this was the Medtronic 670G system, no change in A1C and significant overnight improvement. So this leads us to the AIDE study and the AID in older adults. The acronym Rich Crackley at Advent Health in Florida came up with. This was a 4-center study. So also included Professor Weinstock at Syracuse and Mike Rickles at University of Pennsylvania. So this study was powered to show a difference in hypoglycemia, and they used the tandem system along with their predictive low glucose suspend system, the basal IQ technology that is being phased out. So we had 3 12-week periods. The same patients used 3 12-week periods. And by design, 30% had to have mild cognitive impairment. So the entry point was greater than 65 years. Our average age was 71, and the range was 65 to 86 years. And the A1C at baseline was 7.2%. So our primary outcome was CGM time less than 70, and data were analyzed from weeks 5 to 12 of intervention. So during the study, the median CGM use was 98%, and median AID and predictive low glucose insulin use was 97 and 96%. So people used it for a very high proportion of time. So our primary outcome was time below 70. And as you can see, hybrid closed loop and predictive low glucose insulin suspend, the green and the orange here, do substantively better than sensor-operated pump. We can also look at CGM hypoglycemic event rate per week, which we did here, a priori stated analysis, and predictive low glucose suspend and HCl do better, and coefficient of variation, AID does best. The A1C improvement was 0.3%, so 7.2 to 6.9. And for the first time, elderly individuals who do this do not have more hypoglycemia. So this has now made it into the standards of care for older adults, ADA statement from 2026 January. And again, dramatically, we can see overnight improvement is much more with HCl, and as expected, basal IQ does not have that difference. So severe hypoglycemia and device-related adverse events were looked at in great detail. We didn't expect them to be different, but we recorded these data for safety's sake and also for powering any future such studies. So our conclusion is older adults can effectively and safely use the system, and it's very robust. The control IQ system in these people can improve hyperglycemia and A1C. And we a priori had a 12-week extension phase, so 75 patients opted to be in that extension phase, and 91% chose AID. So we had a pre-specified analysis of that we published a few months ago. And here on the slide, you can see that that during the extension phase, that improvement, both in time below range and in time in range, was sustained. So this study was, though using the control IQ system, actually funded by the NIDDK through RFA grant. So this was a patient in the study, a 66-year-old with type 1 diabetes and 10% time in range, endeavoring to keep the A1C as good as possible. And you can see her characteristics here. Initially, she did have an episode of DKA, and we had to repeat the device training. And then towards the end of the study, her A1C improved by 0.3%, her time in range improved by 8%. And after completing the study, she proceeded to use the system further, and her time in range was 0 and A1C was 6.1%. So a robust outcome here. So in the AID in type 2 diabetes, we had a pre-specified analysis of patients in different age groups in greater than 65. You can see that there was a treatment effect of 10% here, favoring AID. And what about the SECURE T2D study? Again, there was a pre-specified analysis, and on that, greater than 65 years, there were 84 subjects. So there have been no dedicated studies about elderly type 2 and AID, and we may not have, and we may not need, because all the data from these enrolled pivotal studies show that there is about a 0.8% or so A1C improvement without significant safety concerns. So AID is safe and effective in elderly type 2 diabetes and as well in pivotal RCT and in clinical trials. We will have more such data coming out through all of the other type 2 studies that are projected to happen in the next few years. So, I think I'm glad to be talking to you. I hope I've kept to time. Unfortunately, I didn't bring my phone on stage to look at the time here, but obviously all this work happens with a very dedicated team. So I've been fortunate to lead a team that is dedicated. Our technology program continues to flourish, and Roy Beck and his team at JABE Center have been a great inspiration to work with, as also other colleagues of mine over the years. So I'm glad to take questions. And again, thank you for this privilege.
Well, thank you, Dr. Kudva. That was really eye-opening. The big concern, obviously, as a cardiologist, is the fact that there was weight gain, and everyone knows the beneficial but still anabolic effects of insulin. And so, if you're delivering it better, the weight is going to go up. And it was interesting that you had the GLP-1 receptor agonist data to try to mitigate that. So I'm thinking that going forward, and because you correct me if I'm wrong, but as I was going through the studies, it was the shortest was the 13-week, and the longest was 8 months in Australia, right? And so if you think about 1 or 2 years and just of increasing weight and potentially cardiovascular risk. So what are you all thinking in terms of adjunctive therapy to stop that from happening?
So in the type 1 cohorts, the weight gain is much less. In the type 2 cohorts, there is more weight gain. So the weight gain is somewhat mitigated by the GLP-1 receptor agonists, and more powerful ones are coming up. So therefore, I think those may have a higher impact on alleviating the weight gain. So in the type 1 space, we are happy that tirzepatide is being tested in pivotal studies with FDA indication at this time. So we expect the results of those studies to become available in the near future, maybe next year or the year after. And Satya and I are involved in other such agonist studies, both in type 1 and then in future in type 2 as well. So I think we will have more emergence of such data and the impact on weight gain. Now, the other issue is the issue of cardiovascular endpoints, and in type 1, certainly we need to do much better, I think we need to understand why it happens, why do CV endpoints events happen much more frequently in type 1? Our conventional risk factors don't allow us to predict that risk. So that has been an NIH interest and a breakthrough T1D interest more recently. So we are hoping in the next few years we can advance our understanding there, So the NIDDK has put forward RFAs in the past. I say in the past because now RFAs in this space seem to have stalled in the last year. There is a type 1 kidney precision medicine project to do research kidney biopsies in type 1 that will allow us also to study eye outcomes and cardiovascular outcomes and understand the reasons for those. So I think, Dr. Williams, we're just trying to approach this from multiple angles, but you're right. I think our understanding is insufficient and this is a work in progress.
Well, appreciate it. Yeah, and I didn't mention as part of the concern is insulin is atherogenic. And the higher it goes, the more plaque is formed. It's great for growth, but it's got downside.
Dr. Kudva, to Dr. Williams' point, I wanted to just add that when there were multiple dose injections versus going to AID, the total units did increase. So there was more effective delivery and, less hypoglycemia. So there was certainly some advantage to that, which sort of mitigated maybe the weight gain.
Yeah.
And like Dr. Kudva mentioned, the SGLT2, GLP-1 studies will probably help us a little bit more in that area.
So I assume in these studies, there was no GLP-1 added, correct? They were when they were in the study, they were on the GLP-1. Is that right?
I'm sorry, I was looking at the chat sheet because I was overwhelmed. There were 36 things there, so I was trying to scroll down. Can you say that again?
No, in these trials, there was no GLP-1 added. They were there at baseline.
Yeah. So by design, in both of these pivotal studies and going into the future, none of these non-glucose agents can be escalated in the last month. So therefore, they have to be they have to be stable for a month before they can be screened. And then during the trial, they cannot be modified. We did not a priori do an analysis of dose, that may have been too much. I think one of the less comfortable things is how much do you pre-specify as analysis, we already probably did 60 different things. So therefore, but the last point, actually going back there, is the change in insulin dose, in the AID group. Actually, with GLP-1, there is a decrease of about 8%. How meaningful that is, we don't know. But we probably expected more than that, and when we do these in AID systems now, we generally advise probably a little more than with 4 doses or 6 doses, meaning terzepatide is 6-dose amplification. We probably say 10 to 15% per step rather than 8%. But that's all learning as we go along. So one of the questions on the chat is about CGM and glucose measurements in the laboratory. So important points there. I think patients still need to be educated quite a bit about the difference in CGM versus finger prick. The numeracy there is an important issue. So the 20-20 rule, so 20 milligram on either side when the glucose is below 100, and 20% difference when the glucose is greater than 100. So it's always good to have like a dot phrase related to that in your EMR so that you can put that in there, particularly for people who may be somewhat suspicious. So as the glucose signal comes down, there is no doubt that there is less precision, and I think we see this in all those tables that are constructed. That is one of the challenges we face when it comes to hospital CGM. I think there is a great need for hospital CGM, but how should the study be designed and how much should be the difference be and how much will the endorsement be by hospital providers? Those are all, I think, active issues, CGM itself to become non-adjunctive didn't happen till 2015 in the outpatient space. In hospital, I think calibration probably needs to be done every day, So a factory calibrated probably won't work in hospital. So I think that but this is a sea change in the field, So I don't do hospital as much anymore, but I'm actively engaging with our hospital group to try and set up a pathway for rollout. And I think Satya and their team and we discussed yesterday very productively about how hospital systems can approach the future. I don't see any more questions in the chat, so anything else here, or if I missed something in the chat, someone can point that out.
So, Dr. Kudva, that was a great presentation. Thank you. And I don't know if the fellows mentioned to you, we have a 2 half-day insulin pump clinic at the VA, which we have run successfully last 10 years or 12 years, including our 2 nurse practitioners there.
Right.
And we have almost maybe 100 plus veterans on that. And that's pretty reflective of, your study. And some of them, one patient is in his mid-80s and doing amazingly well. What I was always concerned, which I see sometimes, painfully so, is when they get ill or if there's dementia and everything, then we have to keep, quickly change rapidly back to. And did you see any of that? I know yours was a shorter study, but I didn't.
Yeah. So that's a great question. I think so. I didn't mention this, but the NIH encouraged us to come back after our AIDE study with a grant which tested various additional challenges. The one additional challenge that they have funded us to do is to evaluate whether with a care partner in moderately or severely advanced cognitive deficiency, AID can be implemented safely and successfully. So that is the study that we are in the process of starting now. Our funding got delayed with all the changes at the NIH. And so though we finished the AID in 2024, we haven't been able to start this till the last quarter of this year, but we're going to address that issue. In that RFA and in the NIH vision, those points that you articulated are additional factors to be addressed, for example, further transitions, and how do you restore them, right? So if they develop an acute event and that compromises glucose control, are they now ready to go back on the system? And will that system do as well for them, And also nursing home populations, for example, So the great, I think, opportunity going forward is the more fully automated AID systems. Those may not, I think the initial endeavor there is to be non-inferior. So the fully automated insulin delivery systems, our expectation should not be that they will go from 70% to 80%. I think our expectation should be that they will stay there in the 70%, but with less patient engagement, and patients should feel less burden. I think that would be the first goal to fulfill, I think. So we'll see where that space takes us.
Another question was also, you had talked about the minority groups.
Yeah.
One challenge I see all the time is having devices, right? Affordability for devices. And some of them, they come back and they couldn't pay their bills for the cell phone. So they're out of the AID. So how did you tackle that? Were they provided Androids or something by the company just with the apps alone? Did you do those kind of things? I know there was something like that done in the past for CGMs.
Yeah. No, in the AID studies, we didn't provide them with anything else. They had to do it through the Tandem system, The Tandem app on the smartphone was not functional until like 2 years into the start of the study, So the AID study was funded in early 2020, and the pandemic happened at that time. So we got delayed in recruiting, And then Tandem got delayed also probably in rolling out the app, And we didn't factor that into the design, And Tandem wasn't keen, to do it either. So therefore, we didn't have anything like that, More recently, we've done some work with the smartphones and smartphone apps. I think one of the challenges here is going to be what can you not control, which is going to impact the technologies that you want to use, And one of the things in the cell phone industry is the ability to conserve power, So as one of the impacts of that is that certain alerts are going to be silenced or minimized, And that we have no control over, I think if you're going to use cell phones and smartphone apps to power these systems, alerts are part of it. And if your cell phone is, with its bigger platform issue, not going to give you enough weightage regarding that, I think it compromises our safety, and even our applicability, That's one of the things that, as SGLT2s, for example, are tested in type 1, particularly to change cardiac and renal endpoints. ketosis minimization. And, if you think about guidelines there, etc., I think it's too complicated for patients. We cannot give them these big cards with like 4 columns and 8 rows and expect them to go through those cards each time they have to do something like this. I think there has to be a point of care decision support on the smartphone, which will guide them through this. But for them to have that, you have to have a smartphone that is compatible with what you want to do. And that's, it's a bigger challenge.
So we have just 2 more questions that are online.
Yeah.
We could do them sort of lightning round.
The first one there is Dr. Dryden from our gastroenterology.
So long-term clinical outcomes are based on a 1% decrease in the A1C. What would you expect?
Well, it's a continual improvement in terms of complications. So I would expect that there will be an impact on all of these complications. The impact will depend on what your baseline complications are, And so therefore, I think if you look at a composite outcome of complications, macrovascular, microvascular, I think there will be a difference.
So the second one, patients who are motivated to have tight glucose control have tighter success rate of smoking cessation. If that's been looked at, that would be fantastic.
No, we've not addressed that. We've not addressed the smoking issue. The good news is the smoking proportions are much less now than before, but we've not looked at that.
Not in Kentucky. So in Chicago, when we walk into that is the thing that gets my heart rate up. It's a smoking diabetic.
Yeah.
And we have a lot of them. I don't know how you get it. It's worse. Yeah, it's tobacco growing state. I've never lived in one. So, all right. Well, this has been really informative, and really appreciate all that you've done in the field and all that you're guiding us. And we're really appreciative. And thank you very much.